Okay, so we are going to transition into what we are now affectionately referring to the Medicaid Demonstration Toolkit. We have been, Lena's on the phone, so I should say this very carefully. We have been instructed that this is no longer a waiver, it's a demonstration. Some of us like to call it the waiver because you all know what the heck I'm talking about after 2 years of talking about the waiver. So we'll see if I comply on this one or not. So Lena just commented, yay. She loves it when I am compliant. So I provided this overview to our board last Friday on our retreat. Took us about 3 hours to actually get through it with all of the questions. We have approximately 50 minutes to get through it. So there's no way I can possibly answer all of your questions. So Hadley had a brilliant idea that we should have you write your questions down, and we will work to both create a blog post that answers them to the best of our ability, but probably more than anything, push them out to the healthcare authority who can factually answer them and or say we're not sure yet. So you've got sticky papers in front of you. Please be as descriptive of what those questions are. I think we'll go to the next. Yes.
And for our folks on the phone, we want the opportunity to give feedback as well. So up on the screen right now is the YouTube survey monkey, which it should have just been put in your chat box. In there will be the same ranking exercise that we're going to be doing after we go through the toolkit. There's also a questionnaire where you can leave comments in this survey, and we'll be compiling all that to send along to the station.
Yes, that's a great point. So Better Health Together will, we're in, actually let me back up. So right now we are in the 60-day open comment period in which anybody can provide comments on the toolkit. Better Health Together is working on feedback based on our exercise today and some conversations at our board retreat on Friday. So we'll have a formalized letter that we'll share with you. I can't stress enough how critical it would be for each of your organizations to also submit feedback. And any thank you, we're really glad to see flexibility in how this work gets done would be super important in light of all of the healthcare changes that are in front of us. So I'm going to dive in here. This is just to remind you there are 3 initiatives. Initiative 1 is really the one we're going to spend time on. This refers specifically to the toolkit. Initiative 2, we now all have a great working knowledge of. And Initiative 3, we're sitting with bated breath waiting for some detail on that. I expect probably by March Leadership Council meeting, we should see enough detail and information to be able to share with you. The second thing that I think is really important on, you can actually go to the next slide, on Initiative 1 is to remember, though it's $1.1 billion that are sort of earmarked for Initiative 1, this is all money we have to earn. There is no hey, good luck, do a good job, here's a bunch of money for you to be creative with. They're going to be very targeted in year 1, sort of process-related deliverables to earn the dollars. And by probably year 2.5, you got to be delivering on actual results. So this is, I think, probably what we're going to start to see a lot of, which is that pay-for-performance mentality, deliverable, and so forth, which I think for our region, we're going to do exceptionally well in that, so it doesn't really intimidate me too much, but it is, for anybody who has had government contracts, it's slightly different. And for those of you who've been mostly philanthropically funded, I know I've had the experience of saying, I'm going to accomplish this, and then come back at the mid-rear and say, I'm not quite getting there, but there's some awesome stuff that we're doing, and you sort of get away with it. There's not going to be any getting away with any of this. So we're going in eyes wide open. So you can see on here there's some key goals that we are trying to align with. I think it is really important to recognize this is really a community-wide change management process. There's a lot of technical process improvements to the delivery system, but in a lot of ways we are changing mentally, behaviorally, how we are engaging in both the healthcare system and the social determinant of health system. And you'll see this as we start to go through and acknowledge the models that are tied to the toolkit. This is very evidence-based. This is not innovation money. This is not, we've got a great idea. There's going to be a very deep tie to what has worked and how do we scale that. I think we've covered the rest of that. This, I think, is probably the single best slide to sort of wrap your head around the toolkit. And we're going to walk through each of these, what we're referring to them as project areas, which feels a little narrow compared to how sweeping they are, but for the sake of simplicity, we will do that. I am really, really pleased with this graphic because I think it shows the fundamental infrastructure piece that has to be built here before you can get to here, before you can really move on these community priorities. That'd be the good news. The bad news is we're going to do all of this at one time, regionally and statewide. Seems like it'll just be smooth, right? Like, can't see any hiccups happening there. So I'm going to walk through each of these, but I think if you can just sort of keep that in your mind as a structural organization of the work. You guys are doing very good with no questions so far. Which makes me also feel incredibly confident at delivering this, since this is only the second time I've actually walked through this. So, financial sustainability through value-based payments. We've been talking extensively at a 100,000-foot level about changing from a fee-for-service healthcare system to a value-based system. And it's super complicated, and it's going to be really, really hard. But we have this incredibly audacious goal that by 2021, which is a mere 5 years from now, 90% of all Medicaid payments will be tied to value. I have this handy-dandy spectrum of value-based payments, of which value is sort of all in this. We've not received a lot of guidance of what will tell us how we will meet that or what our current standards are. We do know that in 2017, 35% of all payments will need to be value-based. And bless our Medicaid managed care plans for the patient and gracious way that they are embarking on doing this work. This is where I think some of the complexity really, really lies, is as a region we want to encourage that. And this is really a contractual relationship between insurers and providers, with the healthcare authority overseeing and managing all of this. So in some ways, I think we're going to act as the cheerleader. And the part that we can be really helpful with is all the social determinant of health connection points to healthcare, so that our providers can really be successful in meeting the health outcomes that we're trying to get to. So you'll see, we tried to keep this in sort of a similar way. So these key planning activities. So as an ACH, we're going to be accountable for establishing a regional value-based payment adoption plan. Great. Check. Okay, now we're moving. Now we're moving on.
Can we have more talk around that? Because one of the things that's hard for our organization to comprehend is just really what that looks like and how that all works. I think there's such a blindness there. And since you said that, July 1st, we're going to be rolling this out and we don't really have a long time to plan.
Okay, wait, before you go, July 1st is just Initiative 2. We will
Okay.
talk about
Got
ACH timeline, which is fast, but not that fast.
Okay, thank you for that. But just to have,
Absolutely, and there's
that
going to
we can
be,
prepare.
absolutely, and I probably should have started, there's going to be a ton of opportunity for community engagement around a number of these areas, and next month we'll come with sort of, here's our plan of how we think we can move across all of these required activities and potential optional activities. There will have to be a significant amount of sort of knowledge building across a variety of different segments of the community. There is some work being done through the Healthier Washington initiative called Practice Transformation that they're just sort of getting ready, which will help link both the value-based payments and the new modeling that goes with that with actual how do you get your business or your organization ready to do that. So without a doubt, there's a lot more information coming. Some of it we have, some of it we don't. Hopefully everybody is signed up for the healthcare authorities. Weekly, though, it's starting to feel like daily updates on all the different things that they're trying to move forward on. If not, we'll add that to our blast where you can sign up.
And so for the community, what you're talking about, research and all of that, I feel like we've done really good work. Like Tony and I, with a couple other people I know that are in here, with the population health groups that you guys have led. I feel like we have a lot of good research already to start with, and I guess what I'm looking for is a next step so that all of us around the table that have programs and things to connect to it, how do we get ready so that when you say go, or when you get that quick thing from the HCA that says, okay, you guys have to have all of your projects in line, how do we be more prepared for that?
You bet. That's exactly our role. Okay, we're going to keep moving through. That's only one. And the really interesting stuff is later on in the presentation, so I'm going to tease you with that. Domain 1 workforce. I was delighted to see this as sort of a core element to the transformation project toolkit for a couple of reasons. One, we talk very, very consistently about the provider shortage issues that we have and some alternative ways of delivering care. We've never really, as an ACH, moved beyond like, oh, that's a really big issue we should try and focus on or think about or have some strategies. It just has not really bubbled up other than we know that's a risk. So to have a full or a specific project tied to this, I think will be really, really excellent. As the toolkit is written right now, it's pretty broad, which I think they are getting a lot of feedback in. This is a 5-year demonstration project, and to actually deal with the, let's say, primary care, nurse, psychiatry, mental health, provider shortages in this region alone is going to take a much more concerted effort than just 5 years of work. We are starting to hear some hints that this will really be about how you are building up in some critical shortage areas, of which I think you could go through a long list in our region, particularly, as well as the connection point to community health workers. So I think we'll see some further narrowing of this. We're really excited about the opportunity for the accountable community of health to also be linking up with the workforce development councils, the rural economic development agencies, and GSI's efforts to make sure we have both a short-term and a long-term plan. This is going to be super interesting to watch the statewide efforts and how our work aligns. There have been no less than 12 statewide task forces dealing with a variety of different provider shortage issues. So there are a number of us pushing really, really hard to say, don't redo what all of that work is. Can we synthesize it and prioritize it and figure out how could you actually have the most amount of impact in moving that along. This becomes really important, I think, for our area and our ability to both deliver on some of the community priority issue areas, as well as this movement to value-based payment. If you don't have enough providers, it really doesn't matter how high a quality it is. So we're going to pay a lot of attention to this, and we will definitely have a sort of community assessment of where we're at with both current shortages, but also the plans that are already in place. Okay, moving on. So the System for Population Health Management. So when you read that, doesn't that just seem like something more than technology? So let's all just take a collective, oh, it's technology. Which, you know, we can sort of let that be a little fuzzy and say, well, sure, now we're going to have data to be able to look at population level data, but you can see that the real core of this work is the integration of health information exchange. The state is investing literally a gazillion dollars in trying to figure this out. We are going to all put our best positive thinking that they will be successful. This feels to me like one of the riskiest parts of the work, that until you actually get all of these diverse systems talking to themselves in a proactive and easy to understand, usable way, it is just really, really hard. So we are going to have to talk in our region about sort of how we're doing with that and specific activities that we can do. One of the other things that I would add is we're unclear of these 9 areas how that $1.1 billion gets split up. And while I don't want this to sound like the Healthcare Authority hasn't thought about it, I think it is dependent on how each ACH region puts together their overall project plan for us to look at how that sort of fits together. So I think we were joking on Friday at the BHT board meeting, we could spend all $1.1 billion just on this and maybe still not accomplish it. So important, scary, risky, fingers crossed. Okay. So now we're going to move into, so those first 3 were all projects that we have to participate in as an ACH, have a project plan, have a team, etc. As we move into this next, there are a couple that are required, and then there are several that we as a region get to decide what we will accomplish. I will say that my heart starts to palpitate when I think about us trying to move forward on all of these different fronts at one point. So we'll just have you have that in your head, that I think there will be some hard choices coming forward. But one of the required is bidirectional integration of care and primary care transformation. So this becomes there's a couple really key points to this. Number 1, we've been on this process because we know whole person care is best delivered when behavioral health and physical health, and for us, oral health is all integrated into a full care system. The state is really thinking about, like, let's do the behavioral health and physical health, and I think our region is going to keep pushing the oral health part into fully integrated care. But you can see here that in order to sort of meet the goals here, we have to select one evidence-based approach for integrating behavioral health and one emerging for primary care in the behavioral health setting. So this is where this gets pretty interesting in terms of what's currently happening, what do people want to do, and this slightly bizarre leadership role that the accountable community of health, which is not me, it's us, helps to move that forward. So I am intrigued for some further guidance on how does one approach this. And in the meantime, we know there's been an amazing amount of work around patient-centered medical home all over the region, and a number of great examples of, if not full integration, a lot of movement towards that. The other thing I'm going to draw your attention to, which is consistently noted in every one of this, which is development of a payment model. So this is where the value-based payments actually meet with these different care models. At the end of the 5-year period, we must be able to demonstrate that grant money or waiver money is not required to be able to carry forth the structures we put in place. So you've really got to be moving away from, we have 5 years to pay for this and we got to figure out how to pay for it for the next 5 years, into these models become sort of core business operations for providers, for payers, for community organizations. So it's a big shift. I want to let that sort of settle in your brains. Okay. Now we're moving into hypothetically an optional project for our region. I giggle about this a little bit because, as you remember, we selected the Pathways Hub model for our regional ACH project. And it is gathering energy and steam for our first launch. So we were delighted to see it listed in the Transformation Toolkit as an optional project. I think there is probably good energy building amongst a number of our partners who've been working with this to have this be one of the optional things that we choose. Since we've got a number of new folks, we have produced two pathfinders, we're calling it in our region, videos that sort of start to kind of explain what it is, not in a policy slideshow PowerPoint way, but like, how would this work? So we pushed out to you all maybe 2 weeks ago our Meet Joe, which gives you an example of how this works from a client perspective. And just this week finished Kathy, who is a community care coordinator. So I'm going to indulge you with just a quick.
Meet Kathy. Kathy is a community care coordinator employed by a local nonprofit. Kathy's organization is part of the Better Health Together Pathfinder Community Hub, which makes her part of a regional network.
Great job, Hadley.
And yes, that was Hadley. She loves it when she's the one giving the presentation and then puts on Kathy or Joe. We'll push those videos back out. I would just continue to encourage you to share that with folks as they're pondering, what is this Pathways hub? That, though, is not part of the waiver toolkit, so hooray! Hooray, hooray, hooray. I will say that I think one of the important things as we think about these Domain 2 and Domain 3 areas is this linking back to workforce, technology, partners, and financial sustainability. As you'll see in every one of these Domain 2 and 3 projects, being able to scale and sustain it post-waiver period and paying for the outcome will be critical. Moving on. So this is where it gets super interesting. Based on, I think, a lot of the innovation that we've done in this region, we're a little unclear of how many of these models are actually in place or some of our innovative efforts have built on these models. So I love using, actually we'll do diversion next, but I love using the low acuity as a great example of community came together, solving a problem, but it is sort of a new practice, although based on all of the research that was done, I'm imagining some of the practices are there. So we're a little unclear of, is there flexibility to take a program that we have incubated and evaluated locally and frame it into this, or are we going to have some creative writing skills to be able to link the foundation of this model is reflected in the work. So you can see a number of care management and transitional care models here, as well as some utilization suggestions here. So we are going to have to start to get really, really knowledgeable about these areas. So I would sort of invite you, if your organization is using any of these models or practices, we really want to know so we can start to link up of what does it actually mean, not as a hyperlink idea, but as it's in motion. Domain 3 around diversion interventions, I will say that we are very, very pleased.
Can we go back a slide? I'm sorry. So when you say we have to use one or more of these approaches, what I'm hearing is moving forward as we come up with strategies to meet the goals, they need to align with
those models.
Okay. And maybe I'm late to the game, have we received information about these models so we can...
No, but you could hyperlink, click on any of these, and it takes you to the full
So I have this document somewhere?
You will after today's meeting.
Okay.
We'll send the slides out for everyone. It's also actually in the toolkit. There's a number of places.
On the website.
Without a doubt.
Okay.
Without a doubt.
Thank you.
So diversion intervention. So as I was using the example of the low acuity program, we also have quite an ED diversion set of efforts happening for sure in Spokane County and sort of where appropriate in our rural communities. The community paramedicine and the LEAD program, I think there's a lot of energy around that, around the region, and we're going to have to be really thoughtful about, are we willing to align with these models so that we can earn those dollars, or do we sort of keep bootstrapping the work that is happening? This is, as is the transitions, an optional project. Keep going. This is a required one. So it was great to hear that HRSA's got some more money coming out. I think the more we learn about not just the national epidemic, but how this specifically is playing out in our local region, it is nice to have that focused work and resource being available. The couple of key things that I think we look at up here around these goals is this is really a sort of whole set of strategies. It's not just a single set of interventions, but it really works to try and get a little more upstream as well as providing capacity. It also seems incredibly hard and complex, as you'll notice a theme through all of these, which makes me, again, sort of challenge all of us to really balance that do everything, do a few things well mentality that I think we're going to need to work through. Okay, moving through domain 3. This is the health equity through chronic disease prevention and control. I am delighted to note that a number of these recognized evidence-supported disease prevention efforts exist already in the community, but in like little teeny elements all over the place. So the idea of trying to think about how to scale that, I think it's to be really, really exciting, and the chance to be able to support people who are not just in that sort of crisis phase, but really how do you move yourself into a longer-term, healthier life status. I would highlight a couple of things here. This is heart disease, diabetes, asthma, and hypertension. So for those of you who did some work in our population health, a lot of alignment in that way. Okay, maternal and child health. This is a great example of, I think, where there's going to be some push-pull on return on investment from models. So most of us who have done anything in the maternal child health way would recognize these models as incredibly effective, and for some of them incredibly expensive. And so as we think about the long-term benefit of investing in early, so prenatal or even pre-prenatal when we talk about preconception, to sort of that age 3, and the potential for improvement in health status over a lifetime, resulting in cost savings to the system, pretty hard to not get excited about that. And we're talking about a 5-year demonstration period. And let's remember our 6-county region, how big, diverse, and different population centers as well. So I think that's going to be an interesting one to really delve into energy versus return on investment. Oh, our friend oral health. We were delighted at seeing oral health in the toolkit, and then had a moment of like, oh, so these are our evidence-based models to look at, which are lovely, like no actual concern about the models in and of themselves, but based on the access issue and the financing issue that has sort of dominated our conversations, this has felt less sufficient. I'm really delighted to hear that the Washington Dental Services Foundation is providing in their public feedback a transformation toolkit for oral health transformation to try and encourage a more diverse set of strategies. So I think this is another one where I think it'll just be interesting to see where we end up with in terms of strategies, and then whether or not we can add another thing to our primary care docs to-do list. Not always the doc, the primary care team to be able to deliver on that as we're looking at full transformation. And this may be the perfect time, and that is actually something we all want, and that's pretty easy to do. Or it may be the straw that breaks the camel's back. So more delving into that. And for the moment, we're glad oral health is noted, and we're going to hope for some good feedback from some of our oral health providers to say, and there are a number of emerging strategies or evidence-based strategies to work.
So as one of the oral health providers, and again, to help me understand so I can respond in the public comment period, does this mean that moving forward, any programs that are developed have to use only one of these two strategies here? Is that why you're expressing?
To be eligible for the outcome payment.
So one of
that would not prevent any other community effort that was funded by.
Right, but right now we're concerned about having access to this large fund of dollars. So right now to have access, we have to be in one of these two evidence-based access models, unless during the public comment period we are effective in bringing forward other models to suggest to put onto this list. Is that accurate?
Correct.
So in the public comment period, if we can be specific about what those models might be, that would be useful.
Being specific would be very, very important.
Thank you.
And also, where are the, if Washington Dental Service Foundation or whatever is providing this strategy or framework, where can that be found? Is that?
We don't know yet.
Or
we just learned about it on Monday. So all the public comments are actually posted. They are for public comment. So eventually you'll be able to see them on the Healthcare Authority's page.
Will it be during the public comment time, or?
I don't know if it's real time.
Yeah.
Sometimes it is.
Well, I know they're doing strategy meetings, but
I believe they're trying to do
They're trying to do that, yeah.
after the public comment, which is a concern for me as a leadership member, being part of the oral health. I would like to see those things prior to, or they can't be part of it because, we have to use one of those two strategies. I would just really like to see more access to those kind of things.
We have requested it.
Okay.
For sure. Okay. So oh no, okay, yeah.
Just on the heels of that question, just one quick one.
Sure.
What is there an outreach effort to private practice at all to be involved in the comment period? I mean, if this is our community collaborative
That's
organization,
a great,
seems like a crucial,
yes, yes.
better get the word out that.
Yes, there's a ton of effort to engage providers, broad community in feedback. I would say that many of the professional associations, so pediatricians, primary care, medical association, dental association, hospital association, FQHC association, behavioral health association, are all pushing this out to their members to comment back. So there's definitely, I think, some push in that way. On Sunday, March 12th, the Healthcare Authority will host a public comment period here in Spokane. I think it's at the Regional Health District, actually. We'll add that into, they just set the date this week. We'll add that into the Leadership Council update. So that'll really be the sort of public part of that, though we welcome, any opportunity we would have to present to groups, gather that feedback, and or sort of further synthesize.
So what are the dates of the comment period then?
I think it's February 2nd.
Yeah.
Closing, so that doesn't give enough time.
February 2nd, it's already
Yeah,
started?
isn't it February 2nd?
I think
so
6th.
I
something
thought
like that.
that
Closing?
it was January
Say that again?
2nd.
So the 60-day period is already open and now and then it's closing? February 2nd? Okay.
And we have
Is that right? Or is it
That's for the toolkit.
just for the toolkit? Yep.
Second is just the comment period for the toolkit. And
Yeah.
I think
March 12th is the
and
full
March
waiver.
Is the full waiver.
And so
No,
I guess,
transformation demonstration efforts.
so I'm concerned by being the leadership council and being the driving force is what this group is what's going to charge this forward. And we have a lot of say, per se, but it's so hard to chew on, like you said yourself, that even it took 3 hours for your board to even get part of it. And if we don't have a clear concept of what this is and be able to ask questions, how can we have a comment time? And so I'm concerned, and I think that we need to have a 3-hour session, and I'm requesting that on record as a leadership council. I want it broken down so that I can make a good, educated comment and not be misinformed and miss the deadline.
Sure, I'm happy to host that. I will say that it is so important to recognize that it took the state 19 months to negotiate with the feds to get to this point. So I don't actually imagine a lot of change occurring from this, and that this is a piece of an overall transforming system. This is not the end-all, be-all of everything that will need to be done.
But
And
this is how it works, is that the little pieces are put in place, you know, one at a time. And being a lawyer, I'm here because I'm concerned that everyone's legal, you know, are we really doing this in a way that is community-based? And so these little pieces, they still matter. Each piece, as you decide on the toolkits,
Right.
that matters a lot. And if there's only certain key players in the community that know about these toolkits, then suddenly everyone else is excluded from the table. So I really value the comments that are being made, and it's not anything against anybody,
No.
but trust your instinct. If this is the comment period and this is what we're going to comment about, you know, make the comments, because you don't get to preserve those rights. As pretty soon we have a system and everyone says, how did this happen? Well, it happened over 5 years with little tiny Legos, you know. So each piece is important and it's valid, and the comment period is a legal thing. This is the part,
Right.
the legal period where you can do this. So
And I think it's really important to recognize that over the last 2 years of ACH development, these conversations have been happening. And over the last 4 years of health transformation work across the state has been happening. So I would challenge that when you look through each of these domains, there's expertise in the state who are already operating on these, and that there was a very concerted effort when we did the all-call, you know, what could the waiver be for funding to be able to accomplish this, that really got synthesized into best practices work that could be accomplished in 5 years. So I hear you 100%, 100%. And it is not perfect. And it is going to leave people who are going to be like, I didn't know about this. Absolutely. There's just no way around that. And we're committed in this region to being accessible to explain things. Would be happy to host a deeper dive into these things and try and pull some particular partners who are actually doing it so that it becomes real. It is very challenging with as much diversity of knowledge sitting around this table to use your time super efficiently. So we're happy to do that. And we wanted to give you sort of here's the working knowledge of these 9. We're not deciding anything today. This is still in the public comment period. We may see some adjustments based on that. And we're going to have to, perfect. We can move to our timeline slide. We are going to have to move forward.
I do want to make a comment that builds on that, though, just to the group, and that is that this is a different type of a period that we're in. This is a large paradigm shift type of transformation, and it's very rare that we have the opportunity and the obligation to respond during this period. So it's not a typical, oh, here's another idea that we're going to try to, and things are changing. The whole healthcare system is being transformed as we speak, and it will define how we move forward for generations. So not everybody can be here, and I know you guys have been working really hard. I can't be here all the time, and I have a job that probably enables me to be in these forums more so than most. So I feel really responsible to try to understand it and to try to represent my colleagues that are, you know, in various places in the community doing the hard work at this very minute, right? So access is being defined right now in real time, and this is our real time. It happens to last for years, but I don't think we can afford as a working group to lose track of that. We have to be very cognizant of what we're saying is important moving forward.
Allison, I'd like to just mention that I'm a patient at Native Project. That's where I get my health care, and Dylan Dressler was just here, and she was letting me know that they've already implemented a lot of this stuff. And so if we wanted an organization to come in and present about, you know, how it's going and what works and, you know, all that, I think they would be great. So I'd recommend that.
Maybe even just we could have a list of, I think part of the issue is the is that everybody's busy.
Yeah.
So that if there's a funnel for a list, like if anyone's interested in other kinds of information exchange about this, or if you know people who aren't involved, I mean, maybe we just throw the pad out here to you know, to do some of these things, because not everybody's interested in the same subject matter. But if we know that we're going to talk about these 3 models, whoever's interested can use the room. I think you've said it can be made available. We can be more effective with time.
For sure, for sure. And I don't think there's any organized manner with which these models have been, like we're going to have to go build all of that type of delivery system. And I think being able to use that and align with work that's already happening. And that was I was trying to make that point that we know these conceptual things, and we know that our health systems, especially our FQHCs, have made tremendous strides towards an integrated health system, which is why we feel really confident that on the value-based payment side of things, on the community-based care coordination, we can make huge strides in this region of actually improving health, because we aren't starting at a deficit of like people being like, really, it would be helpful to have mental health sitting at your primary care and you could go to the dentist. Like every one of our FQHCs are already doing that. And both at Providence and Rockwood, there's a big move towards being able to have a more holistic approach. So we just have to be conscious of the amount of synthesizing time, what is interesting versus what could really be valuable and require that community push to be able to get there.
So one of the ways you can include that is to say there's a mechanism for introducing something that could be proved. Like if there's all these different
that's great.
Now,
that's great. I want to keep us moving along, and I'm happy to have an offline conversation with the two of you with some of your suggestions, which are really excellent. So I just want to point out some key points of timeline-wise. So we signed here. I believe technically things started on January 1st, despite not signing until January 8th, January 2nd. So we lost 6 days already in there. So in March, our ACH will submit our designation application 2.0. We have been assured that we are in great shape, and Hadley will just get to do a lot more writing and pushing together on that. And that will trigger sort of a first administrative payment for our region, which will then launch into our phase 2 and project plan work. So you can really see between now and September that we are going to have to determine, of these 9 areas, 1, which optional areas are we going to embark on, and 2, how are we actually going to do that? In the toolkit, which is 78 pages long, that I carry around handily like this at any given moment, there are very specific requirements for what would trigger your payments in that. So what's great is we have a little bit of a roadmap of how we're going to be able to move forward. But I think, you know, the part that is both incredibly exciting and probably very concerning to folks who are worried there hasn't been enough community engagement is they're going to approve in November, meaning December 1. We are moving and grooving on moving forward with these things because of the high accountability to actual outcomes in year 2 and in year 3, 4, and 5. But that's where you're going to really move away from, yes, I have letters of intent to move towards full integration, to you can actually see, based on claims data and other data, an integration has actually occurred. So let's just have a collective like, whoa, in that. Yeah.
So your definition of a project plan is domain 2 and 3?
Nope, it's all 9. It's all potentially 9 areas. So there'll be a workforce plan, a value-based payment plan, a population health plan, an opioid plan, a bidirectional integration plan required, plus whatever of the other 4 optional ones.
The opioid is required.
Yeah.
Pardon me?
Yes.
Opioid is required, yep.
In all projects? Or in, what does
No,
that
it's
mean?
In all regions.
In regions, okay.
Okay.
So here, and I'm sorry to take up time, but this is really important. Because I have an endorsed project, there's only 17 on your endorsed list. And so it's a real concern to me that I want to have my project right and written and everything that needs to be included into that. And so I want to hear more about what those requirements are, and in a public setting, not just offline, because I think a lot of us have these questions, but maybe are not, they're being polite and I'm being pushy. So I will be pushy for our community and ask those questions because I think they're important.
Absolutely. And so January 2nd when it started. January 8th is when they told us they'd actually gotten it. And I will say there were many people on the BHT board that were highly skeptical with the new administration this thing would ever even get done. So I'm going to need a little bit of graciousness here from you all as we try and build out how this will work and having enough guidance. Like you all have absolutely all the information that I have.
Information. So that's why, and you guys have lived it, breathed it, and we're still doing our stuff. And so
honestly, you all have lived and breathed this in your topic areas way more than we have.
Okay.
So, and again, I hear you. I really hear you. And we're all in this together. This is all of us earning the dollars in general.
I think my only comment in listening is, we do have some tried and true methods that are already up and running with Northeast Health Programs and NATIVE Project, and we've got those co-locating bidirectional services up and running. I think one of the things that we can help Alison with as we journey down this road together is that huge question about workforce development and proper data collection and reporting. That's going to be one of our things that collectively in Eastern Washington we're going to need to pull from public health. We're going to need to pull from the tribes and aging and long-term care and community health workers and Planned Parenthood and housing so that we can pool those resources because workforce development is so scarce right now. And we don't have the providers coming out of the school system that we need. And we don't have the providers in the rural areas. Ponderay County doesn't have a paramedic program. They don't have a dentist that takes Medicaid. And so we're going to really have to look and pull together to make sure that when Alison leads the charge with our entire team here, that we can actually deliver upon those domains and those required projects. And so my encouragement summing up is to get together, have those discussions, and pull those resources and look at tried and true, already in place services that are being executed throughout the state, and more importantly, Eastern Washington. And also realize that this isn't just little fun grants here and there. This is a whole collective movement for the state.
Thank you. That's very lovely.
I just want to apologize if I've sounded contentious. That's not it at all, because I feel really supported by Better Health. I wouldn't know what I know if it wasn't for you guys.
Yeah.
It's when you're rolling out the timelines, and I feel like I can't do what you need me to do, that I start to
Absolutely.
sound
Every single
contentious.
person sitting in this room feels that way.
Yeah.
These are actually undoable timelines, and we have no choice.
Or we can.
Or we're going to miss out on the opportunity. Like, this is a once in a generation. And I think when you start to think about what is at stake for other changes, this could really drive how health spending goes moving forward. So I just hope we really focus on what is impact-driven work and not on what could be. Like, this is actually our choices, and we may not like them. I think there is a small window to effect. I think oral health is one of the areas that I am most concerned that is too narrow, and that the actual return on your investment of trying to do that, and on investment, I don't even mean the money. I mean actually the hearts and minds and energy it's going to take to do it, that we know that is crisis levels here, and I don't think that solves our needs. So there's a small window there. The rest of these, I think when we start to cross-reference about what's already happening in the community, there may be some creativeness, and I use my low acuity program as a great example where it doesn't say low acuity transport project there, but there's some elements I have to imagine in the diversion best practice there that we can say, maybe it wasn't, but now it was based on the best practices of that get us there, so we ensure that we're really taking advantage of what is still a fairly small pilot project and getting to be able to scale that. The thing that is exciting to me is this does give us, we either do this or we don't kind of decision point. It does not preclude the community continuing to drive pilot-funded money or pilot-funded, private-funded work, more pilots, et cetera, and that our hope is through the strategy map work that we've done, we've identified there's a lot of work happening in the community that's not actually referenced in here, and we in no way are saying BHT only cares about this. We just want to seize on being able to earn the maximum amount of investment for this region that has typically been under-resourced to do most things.
2 comments in alignment with that. First of all, it's really important to understand that what we're talking about here is only impacting Medicaid. Now, if we do this right, the systems that we set up will impact others who are not on Medicaid as well. So I think that's really important. It's also critically important for us to remember that we've had dialogues here at BHT about things that need to be done that this won't begin to fund. Housing. We talk about the value of housing all the time. CMS isn't paying for housing, you know, but we as a community need to understand how does this integrate with the broader context of things that we must continue to do as a region.
Yeah. I'd hate him to say that, by the way. Yeah. Money won't spend.
I think, Allison, just like we have the long-term care initiative too, or whatever, it would be really nice to understand the third part of that too, because it does talk about supportive housing and supportive employment benefits, not the room and board, not the structure, but I think just to get the broad scope of all of the funding that's coming so we can see the interconnectedness of all of it.
Yeah. Well, and the
And it makes me sad that even as a managed care plan, you haven't gotten like an inside track of like what that is.
Everybody else has, so we're all on that same road, and as the managed health plans and the BHOs, we're going to be administering some of that benefit, so we're as anxious to get the information as anyone else.
I'm going to work really hard for that for our February
that would be really great.
Meeting. What I have heard is it's not developed enough for public consumption yet. So it's hard to imagine how you can have signed a contract for anyway. I will keep my snarkiness to myself. So I'm going to turn it back over to Hadley, and I'm actually going to bolt out of here. I'm hosting a webinar with the Muskegon Jail Transitions Project with some folks from Spokane County. So there are a few of you who agreed to join me. We're actually moving upstairs. I'm going to let you do sort of a final wrap up, and we will see you all next month. Please, please, please call me, email me, stalk me on Twitter. Apparently that's our new favorite mode of communication. We look forward to lots of work.
Can't imagine who you're talking about.
All right, so thanks all. I just have a few final sort of wrap-up announcements. Just as a reminder, I think that we're sort of moving in different directions than we originally talked about, so maybe not all of you feel ready to make comments on these sticky notes right now. It's totally okay. Because the comment period does close on the 6th, I would highly encourage all of you, I will be sending out the link to the toolkit and all of the slides and the link to where you can get public comments, so that if you have the chance to submit your comments directly to the state, that would be really helpful. You're also totally available to send your comments directly to me or anyone from the team, and we will include it in the synthesis of comments that we've heard as we come to presentation board and all of these days. I hope that maybe we could do a small little ranking activity to see if got check out which of these different issues were sort of the most important or where we felt we were most ready. I'm not sure if we really feel like we're there right now, so I'm totally willing to scratch that. I'm going to send out this survey link that I just provided to the folks over the phone so that any of you would be able to give comments on these different projects through the survey monkey, and again, I would just add that to our submission to the state. 2 separate asks on different issues. One, as hopefully all of you know, we sort of reworked the way the Leadership Council is structured so that it's organization-based, not individual-based. That doesn't, you can still represent actions to a community member or public citizen, but we have asked everyone who comes to these meetings to sign what's called our community commitment form. This is just an agreement that you align with our community priorities that says you recognize BHT is focusing on the areas that we have developed through that public feedback period in our first year of development. If you have not signed that form, we haven't seen it, you have questions about it, come talk to me. We have copies right back there, and you can read it and sign it. And the final thing is we are still asking people to submit survey responses for our community linkage mapping survey. The link is up right here, and I'm sending it out all the time. I'll send it in another email. This is the survey that asks each organization in our region to inventory their organizational relationships. So I would say I'm going to help together. I have relationships. I collaborate with the health district and with Meals on Wheels and with Planned Parenthood. I receive funding from XYZ. I refer patients to XYZ. We're going to use all of that to build an actual visual map that shows the relationships between organizations, referral patterns, education, funding, so that we can actually overlay it. This is the exciting part for me with public health data and see where our gaps in care, where our gaps in funding, maybe where there's a ton of duplication that we could actually just move around and fill those gaps. This is a huge ask data-wise because there's like thousands of organizations in our region, and so the more responses that we can get, the more accurate. So more than anything, I would really, really love if you could take that survey and then forward it to any of your community members, friends, your parents, and just anyone who's in our region. We need them to take that survey so that we can build this map. Any questions? Lots of questions, I'm sure. I'm going to be available for the next however long this is. If anyone wants to come chat with me, you can follow up for that group discussion that's happening. Yes?
What, if we filled out that information long ago on all those multiple sheets, have we met our requirements here?
Yes. You
Okay.
are already taking it. You are all good.
Awesome.
I wouldn't mind if you reminded some of your friends.
I'm happy to do that.
With the new administration, some things might change for us and others, I'm sure. So is there a way to update?
That is a great point. Yes, I'm going to check with the folks who built our survey to make sure we can accommodate if someone comes in and answers the question. I will follow up.
Okay. Because
Thanks, Heather.
Thanks, Pam. Thanks, all. Have a
That's the
wonderful
only
day.
reason
And
I'm
all
here.
your
I don't
good
care
luck
for the
out there.
and representation of I like to do it in a way that's kind and friendly.